Hi, good morning, doctors. Today we are on a 37th day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. Today we are at page number 630, chapter Infectious Diseases, chapter 17, Streptococcal and Staphylococcal infections. Let's start reading. Streptococcal infection. Several groups are pathogenic to man. A, B, C, D and viridin streptococci. Presentation is varied for each. So the spectrum of diseases caused by streptococcal infection is pharyngitis, tonsillitis, wound and skin infections, septicemia, scarlet fever, pneumonia, rheumatic fever, glomerulonephritis, neonatal sepsis, postpartum sepsis, endocarditis, septic arthritis, pneumonia, UTI and dental caries. Investigations for streptococcal infection. Diagnosis is usually clinical. Evidence of infection can be gained by measuring changing antibody response (ASO) titers. ASO titers are increased in 80% infections. Wound swabs are positive if infection is on the skin, and throat swabs may be positive if pharyngitis or tonsillitis. So diagnosis is by changing antibody response to ASO. ASO titers are increased. Treatment. Most streptococci are sensitive to penicillin. Phenoxymethylpenicillin 250 to 500 milligrams QDS for 7 to 10 days. Although resistance is increasingly common. Pneumococcal infection. There are 85 types of Streptococcus pneumoniae pneumococci are carried in the noses, throats of half the population. Most people are harmless. In most people it is harmless. Spread is by droplet infection. Presentations: pneumonia, acute otitis media. This one is specific for pneumococcus, sinusitis again, meningitis, endocarditis, septic arthritis and peritonitis, which are rare. So these are four specific infections: acute otitis media, sinusitis, meningitis, endocarditis. These are associated with pneumococcal infection. So we didn't find sinusitis and acute otitis media in and meningitis in streptococcus. Treatment: amoxicillin 250 milligrams to 500 milligrams TDS. This is thrice daily. Amoxicillin is thrice daily. Phenoxymethylpenicillin is 4 times a day. Clarithromycin and amoxicillin in allergic patients. Resistance to penicillin in the community is still low. Childhood vaccinations. Routine vaccination is often offered as a part of childhood immunization program using a 13-valent pneumococcal conjugate vaccine given at 2 months, 4 months and 12 to 13 months of age. Vaccination of high-risk groups. Single dose of pneumococcal polysaccharide vaccine is indicated for high-risk patients who have not previously been vaccinated. Special rules apply to patients who are immunocompromised or have deficient spleens. Booster doses are not needed except for patients with asplenia or nephrotic syndrome, where booster is given after 5 to 10 years. Scarlet fever. Group A hemolytic streptococcal infection. Incubation period 2 to 4 days. Presence with fever. Scarlet fever has a fever, malaise, headache, tonsillitis, rash, fine purtic erythema sparing the face, scarlet flushing, facial flushing, strawberry tongue, initially when white, turning red by day 3 or 4. Treat with phenoxymethylpenicillin 250 or 500 milligrams QDS for 10 days or clarithromycin if allergic. Complications include rheumatic fever and acute glomerulonephritis. Staphylococcal infection. Usually Staphylococcus aureus, occasionally Staphylococcus epidermidis. Carried in the nose of 30% of healthy adults, antibiotic resistant strains are common. Box 17.1. High risk patients for pneumococcal infections. So, who require pneumococcal vaccination? Those more than 65 years of age, those with a cochlear implant, those with celiac disease, with an asplenia or functional asplenia, that is splenectomy or sickle cell disease, with immune deficiency due to disease, that is lymphoma, Hodgkin's disease, multiple myeloma, HIV, or treatment like chemotherapy, prolonged systemic steroids, with chronic heart disease, lung disease, Any chronic heart disease, lung disease like asthma, COPD, renal disease or nephrotic syndrome or liver disease. With diabetes requiring insulin or oral hypoglycemic drugs, not diet control, or with CSF shunt with other conditions where leakage of CSF fluid can occur. Presentation of a staphylococcal infection. So the table was in between, so we had to read it that way. But right now, the current topic we are reading is staphylococcal infection. Usually, Staph aureus occurs occasionally. Staph epidermidis carried in the nose of 30% healthy adults. Antibiotic resistant strains are common with staphylococcal infection. Presentation: Staphylococcus, breast abscess and mastitis, abscesses, furuncles, carbuncles, septicemia, endocarditis, wound infection, osteomyelitis, septic arthritis, pneumonia, especially in patients with COPD, influenza, or those receiving corticosteroids or immunosuppressive therapy. Neonatal infections usually appear in less than 6 weeks after birth. Pustular or bullous skin lesions on the neck, axilla, or groin. Management of staphylococcal infections: antibiotics, usually flucloxacillin 250 to 500 milligrams QDS or clarithromycin 250 to 500 milligrams BD for 7 to 10 days. Abscess drainage where appropriate. General supportive measures. Where possible, obtain specimens for culture before instituting or altering antibiotic regimens. Staphylococcal scalded skin syndrome, page 883. Methicillin-resistant Staph aureus, MRSA, acts as the same way as any other Staph aureus, is carried harmlessly but most occasionally causes a range of infections. It is only different because it is multiple resistant to antibiotics, MRSA, often contracted in the hospital. Decreased tendency for multiple resistance by prudent use of antibiotics. Wash hands thoroughly with an appropriate antibacterial preparation if they appear soiled. If hands appear clean, wash with an alcoholic rub between each and every patient. Follow local policies for management of patients who are known to be infected or carry MRSA. Toxic shock syndrome caused by staphylococcal exotoxin. Risk factors: tampon use postpartum, staphylococcal wound infection, influenza, osteomyelitis, cellulitis. So these are the risk factors for toxic shock: tampon, postpartum, staphylococcal infection, influenza, osteomyelitis or cellulitis. Presentation: sudden onset high fever, vomiting, diarrhea, confusion and skin rash. So toxic shock syndrome will have a skin rash along with high fever, vomiting, diarrhea and confusion. May progress to shock plus or minus death. Management: admit as a medical emergency. Mortality is 8 to 15%. So toxic shock syndrome is a medical emergency. Page 632, other bacterial infections. Haemophilus influenzae, Haemophilus influenzae type B. Vaccination against Hib is routinely offered to all children and immunocompromised patients. Prior to routine vaccination, Hib infection accounted for 60% of meningitis in children aged less than 5. It was also common cause of epiglottitis, septicemia, septic arthritis, osteomyelitis. Infection is now rare. Now, other types. Non-encapsulated Haemophilus influenzae or NCHI usually causes non-invasive respiratory tract infections, otitis media, sinusitis. It can also cause invasive disease in neonates less than 1 month of age and those with comorbidities. Example: malignancy, immunosuppression, diabetes, chronic renal, liver or lung disease. Other H influenza serotypes here: H influenza A, C, D, E, F only rarely cause invasive disease. Management: organisms are often penicillin resistant. If an infection, admit. If there is severe infection, please admit the patient. Clostridium infections: anaerobic spore forming bacilli found in the dust, soil, vegetation and GI tracts of humans and animals. 25 to 30 species cause disease in humans. Presentation is food poisoning. Clostridium perfringens, pseudomembranous colitis, overgrowth of pseudomembranous colitis, food poison. So Clostridium perfringens causes food poisoning. Pseudomembranous colitis, overgrowth of C. difficile following antibiotic therapy, presence with bloody diarrhea, treated with vancomycin or metronidazole if toxin is isolated from the stool. You have to isolate the toxin from the stool. Botulism caused by toxin released by C. botulinum, which is ingested in the contaminated food, presents with neurological symptoms and warrants immediate admission for antitoxin. Wound infection. C. perfringens causes cellulitis, which may cause gas, gangrene, septicemia, plus or minus death. Admit for IV antibiotics. Tetanus. Meningitis. Page 1056. Tetany, lockjaw. There are 16 cases of tetanus and one death every year in UK. Incubation period is 2 to 50 days. Clostridium tetani infects contaminated wounds that may be trivial, the uterus postpartum, maternal tetanus, or a newborn umbilicus tetanus neonatarum. Tetanus-prone injuries are given in box 17.2. Tetanus toxin causes generalized or localized tonic spasticity plus tonic convulsions. So there is tonic plus spasticity and tonic convulsions with tetanus toxin. So all T's. Tetanus toxin, TT, tonic spasticity and tonic convulsions. Suspect any patient not immunized who develops muscle stiffness or spasm several days after suffering a skin wound or burn. Prevention, tetanus vaccine. So it's a vaccine preventable disease. Primary immunization, 3 doses within 1 month between each. Second dose 1 month after the first dose, third dose 1 month after the second dose. So 1 month gap, 3 doses should be given. Booster doses, 1 booster dose every 5 years after primary immunization, 3 years if a child is aged less than 10 years, and the second booster dose at 10 years after the first booster dose. So at 13 years, if you're giving a 3 years old child a booster, that is with at the preschool vaccination, you're giving a booster, right? So first initially you will give it 2, 3 and 4 months, and then you'll give it 3 to 4 years, 3 years 4 months preschool vaccine as a 4-in-1 vaccine, and a second booster dose 10 years after the first booster dose. Open wounds 1089. Box 17.2. These are tetanus prone injuries. Puncture type injuries acquired in contaminated environment and likely to contain tetanus spores, example gardening injuries. Wounds containing foreign bodies, example splinters. Compound fractures, wounds or burns with systemic sepsis. Certain animal bites and scratches from animals that have been rooting in the soil for or agricultural animals. So wounds or burns with systemic sepsis. Certain animal bites, scratches from animals that have been rooting in the soil or agricultural animals. So high tetanus risk, heavy contamination with material likely to contain tetanus spores, extensive devitalized tissue, or wounds awaiting surgical intervention delayed for more than 6 hours. Diphtheria. Cause of Corynebacterium diphtheriae. Caused by Corynebacterium diphtheriae, rare in the UK since of routine immunization, spread by droplet infection, contact with articles soiled by an infected person, incubation period is 2 to 5 days. Presentation. In countries where hygiene is poor, cutaneous diphtheria is a predominant form, elsewhere characterized by inflammatory exudate which forms a grayish membrane in respiratory tract may cause respiratory obstruction. C. diphtheria secretes a toxin which affects the myocardium, the nervous system and the adrenal tissues. So that is why it was so serious infection. That's why it was a vaccine. That's why a vaccine was initially developed, and now it is vaccine preventable. We don't see many cases of diphtheria in our routine practice because there was a vaccine. Um, so what it does, it produces a toxin. Corynebacterium diphtherium produces a toxin which affects the myocardium, the nervous system and the adrenal tissues. Management. Admit for antitoxin and IV antibiotics. Patient may be infectious for up to 4 weeks but carriers shed C. diphtheria for longer. So this one is not routinely there. So we can just note it from here. Patients are infectious for 4 weeks and carriers shed C. diphtheria for longer time. So these people you have to give antitoxin plus IV antibiotics. Prevention. Vaccination. Routinely given in childhood in the UK. So we are giving it at 2, 3, 4 months. Then again 3 years, 4 months. And then again we will see in the vaccination schedule. Yes, these two I remember. In addition, give a booster dose to people in contact with a patient with diphtheria or carrier or before travel to epidemic or endemic areas. So you need to give a booster dose to people in contact with a patient with diphtheria or carrier or before travel to an epidemic or endemic area. So that is a booster vaccine for diphtheria. Pseudomonas aeruginosa. Common. Treatment is difficult due to multiple antibiotic resistance. If suspected, spend specimen for microscopic culture sensitivity. In immunocompetent patients may cause UTIs, wound infections, particularly in the leg ulcers, gives a characteristic greenish coloring, osteomyelitis and skin infections like otitis externa. So one of the cause of otitis externa also. In immunocompromised patients, patients with cystic fibrosis, it's common cause of pneumonia and septicemia. So in a patient with cystic fibrosis, Pseudomonas causes pneumonia and septicemia. Enterobacteria, examples include Salmonella, Shigella, Escherichia, Klebsiella, Enterobacter proteus, Moraganella, Providentia and Yersinia. Some are normal gut commensals. Salmonella, Shigella, Escherichia, Klebsiella, Enterobacter proteus, Moraganella, Providentia, and Yersinia. Some of them are gut commensals, others are pathogen causing. Diarrhea and intra-abdominal infections, peritonitis, hepatobiliary infections, UTI, often E. coli, proteus species are associated with bladder stones, septicemia or meningitis. E. coli is the most common cause of meningitis in the neonates. Chest infection, Klebsiella may cause severe form of pneumonia. Endocarditis is rare. So the gut commensals, they cause diarrhea basically and intra-abdominal infections like peritonitis or hepatobiliary disease in UTI by translocation into the bowel. Proteus species associated with bladder stones, yes. Septicemia or meningitis, E. coli is most common cause of meningitis in the neonates. Chest infections, Klebsiella, and endocarditis, which is rare. Organisms are usually sensitive to trimethoprim. So any enterobacter bacteria are sensitive to trimethoprim. Severe infections require admission to hospitals for IV antibiotics. So that was for the infectious disease chapter. We will continue the next chapter. Thank you. Have a good day.